about 3 years ago, I appointed a deputy chief nurse called Natasha McIntyre. She has a background in renal medicine. She was actually sitting on the board of the renal registry at the time. Then this new national programme around acute kidney injury started to be developed. So it was the perfect storm, really. It was an issue that I was interested in, and I'd got the level of authority as chief nurse to be able to influence that to become part of the way that we did our work in Southern Derbyshire. We involved very early on those clinicians from the hospital, both from the specialists from the renal unit, but also physicians and A&E consultants. Clearly, our medicines management team were involved, our primary care team, and right from the beginning we had a patient representative on our group, and her name's Ruth. So she's been on the journey with us over the last 3 years now, and her input's been invaluable to provide that user standard questions and challenge to us as a group of clinicians. We set up a steering group that was chaired by myself and was reporting in to two organisations really. One was to our CCG governing body through the Quality Assurance Committee, and then also through Derby Hospitals, because our first piece of work was very much acute focused. When we were developing the sequin, we wanted to focus on where we'd get the most benefit, and there were 3 parts of that sequin that were the main focus. One was around admission to our urgent care system at Derby Hospitals, so that was assessment of risk of acute kidney injury. There was then medicines management and reconciliation of individual medications, and then importantly it was around communicating with GPs via the discharge summaries. We knew that was going to be the first piece of work that we needed to kick off, so we did that. And interestingly, we kind of piloted that sequin a year ahead of the national sequin being rolled out through the national standard contract, so our learning was fed into that programme. So we surveyed every GP and every practice nurse in our Southern Derbyshire CCG localities, that's 56 practices, and we got some very interesting and variable results from that piece of work.
We got our general practice involved in a number of ways. Initially we used our e-bulletins and our email newsletters to give AKI awareness raising messages and to involve GPs in looking out for our resources, for instance the Think Kidneys website, and also the primary care guidance that we developed with our renal consultants at the hospital. On another level, we used our locally commissioned service framework to get GPs involved in completing online surveys so we could understand what they knew already about AKI, and then we involved them in consultant-led peer review sessions, and also in some forum events where we gave presentations and had workshop sessions with the GPs, so they could fully get involved in a number of ways in the programme.
The difference I think this programme has made for patients in general practice is that the GPs and also patients in care homes and patients in so being looked after by DCHS, the community services, any of the staff, nurses and doctors who are aware of AKI are much more aware and much able to proactively care plan, for example, so that the programme's highlighted patients who might be at risk of AKI so that we can be much more proactive in thinking about these groups of patients who are on renotoxic drugs who might also be at risk of dehydration, so that whether that's by the weather, whether that's because they've become unwell, and at times when hydration really we need to make sure that that's done well, and we can empower patients as well to make sure that they know about their risk of AKI. There is another aspect that's really key for patients, and those that have unfortunately got AKI or at AKI are already struggling with AKI and they've been dehydrated and on one of the renotoxic drugs, so that they've not been able to prevent it happening. But where it's really helped for patients is that GPs particularly are more informed on their discharge letters, for example, from hospital when there's been an episode of AKI, so that GPs are better able to then know what to do next.
We are now confident in Southern Derbyshire that when a patient at risk of AKI visits his or her GP, a trigger will be given to the GP through the system that they use to prompt a conversation around AKI awareness, and also a printed leaflet will be given to that patient around sick day guidance so that they'll stop any potentially harmful drugs that they're taking if they're sick. And we are absolutely confident that that will happen on a daily basis.
Patients with long-term conditions are much more supported by this AKI programme. Empowering and informing and educating practice nurses who see the majority of our long-term condition patients now, and GPs who often deal with the acute exacerbations of the long-term conditions when AKI is likely to present or possible to present, has kept patients more safe now because we know more about AKI. We can proactively care plan again for patients with long-term conditions and get in there early. Through the AKI project, one of the really important things we've actually, the project has looked at is discharge information from hospital. I think for a long while hospital have known about their episodes of AKI, longer than primary care has, and what's been really exemplary has been that now we have discharge information when we know a patient has been in and has had an episode perhaps of AKI 2 or 3. We understand what that means. We also have guidance on how that's followed up in a way that means patients aren't missed to follow up. I think the AKI project has been a truly collaborative project, something that I'd really aspire to do when I was working on projects myself, in that it was the idea was initiated in secondary care. It was rolled out fantastically, I feel, to primary care. Everybody was aware, and by everybody I mean Southern Derbyshire CCG staff were aware, but also people on the shop floor were aware of the programme. There was a huge education event around AKI and an offer of ongoing education. So having medicines management, pathology, primary care and secondary care intrinsically working together, I think that's been a real key feature of this project that's made it work so well.
We've been on a journey for over 3 years with this now, and I think the biggest thing it takes is commitment. I think everybody from the outset committed to making this work because we saw this as being of real benefit on a day-to-day basis to patients now and in the future.
We're really confident that the Think Kidneys programme has helped to improve patient safety in Southern Derbyshire.